Very good evening, all of you. So it is the case for personalized treatment for tuberculosis through the whole genome sequencing. These are a very new investigation for tuberculosis. So my name is Dr. Dharit Shah, and I am taking this lecture for next 20 to 25 minutes. So you all know that tuberculosis is a phenomenon of iceberg phenomenon, because there are lots of cases hidden in the community that we are not managed to see the proper case, that this is the drug sensitive case or drug resistant case. So as in India, for the highest TB incidence in the world, affecting 2.64 million Indian in 2019 and killing nearly 4.5 lakhs people annually. And day by day the MDR and XDR cases are increasing, and which are newly diagnoses of MDR and XDR cases. So the India TB report 2020 have reported that we miss 10% of drug sensitive cases and 50% of drug resistant cases in India. I think because of the education level of patient and somehow the miscommunication and less different kind of investigation approach of doctors, we are missing this. So this is just a scenario of how many drugs we are using in the MDR and XDR cases. So there are three groups, mainly covering for levofloxacin, moxifloxacin, bedaquiline and linezolid. They are most properly an appropriate drug for drug-resistant tuberculosis. We have group B and group C. So there are almost 16 to 18 different drugs that will treat the tuberculosis patient. So this is just a treatment regimen available in India for tuberculosis patient. First one is rifampicin sensitive tuberculosis, which is drug sensitive tuberculosis, that we are using isoniazid, rifampicin, pyrazinamide and ethambutol for 2 months, followed by HRE for next 4 months till the proper like disease જ્યાં સુધી પૂરો ના થાય ત્યાં સુધી, diffusion છે, TB છે, conso છે, કંઈ પણ છે. There are 3 different other regimen, which is H mono regimen, shorter oral bedaquiline regimen and longer oral bedaquiline regimen. So I will cover some part of that. Isoniazid itself a H mono regimen, so that in that case we are using levoflox, rifampicin, ethionamide, ethambutol and pyrazinamide for 6 to 9 months, which is called as H mono regimen. The second one is the shorter oral regimen. For that 4 to 6 months of bedaquiline, then levoflox, clofazimine, pyrazinamide, ethambutol, isoniazid, hyzod and ethionamide, followed by 5 months of levoflox, clofazimine, pyrazinamide and ethambutol. So you all know that there are lots of drugs to cover the XDR and MDR patient. The last and the final stage of diagnosis is XDR tuberculosis. For that we are giving patient to 18 to 20 months, and in that 6 months for bedaquiline and levoflox, linezolid, clofazimine and cycloserine. So you all know that there are long standing patients, they are chronic for the treatment. So we have to cover the sensitivity properly before starting the regimen. The newer regimen, which is called as BPAR regimen, they are in the pipeline. It will in the India within a short of time. They called as pretominid, bedaquiline and linezolid regimen. So this is just a brief introduction of drugs, but now I will cover the drug sensitivity report. The rising proportion of new TB cases are already resistant of rifampicin and isoniazid in a first line drugs. And universal DST guideline, they told that drug resistant TB in endemic area rather than screening only previously treated patient. એનો ચોખ્ખો એટલે નાનો મતલબ એવો છે કે કોઈ બી પેશન્ટ આવે તો એને ટીબી પોઝિટિવ આવે તો એવું ના માની લેવું કે ડ્રગ સેન્સિટિવ જ છે, બિકોઝ હવે ધીરે ધીરે એવું જોવામાં આવી રહ્યું છે કે ફર્સ્ટ ટાઈમ જ પેશન્ટ સિદ્ધું ડ્રગ રેઝિસ્ટન્ટ ટીબી જોડે ડાયગ્નોઝ થાય છે. સો ફોર દેટ દેર ઇઝ વન ઇન્વેસ્ટિગેશન કોલ્ડ હોલ જીનોમ સિક્વન્સિંગ. સો ઇન ઇન્ડિયા this is the process line. First the government will do the CBNAT, then after CBNAT if something is resistant they will go for first line LPA, then second line LPA and final culture DST. So it will take time from day 1 to maybe 60 days. So almost 65 days has to be there for a patient to tell them that you are a resistant for levoflox, either you are resistant for ethionamide or anything else. So to cover this, the company known as hashtag they launched the whole genome sequencing in India. So what is whole genome sequencing? Whole genome sequencing is a report that analysis of entire genomic DNA sequence of a cell in a single time. It is also called as whole genome sequencing with next generation sequencing and massively parallel sequencing. In that, we have to collect the sample. So in pulmonary, we have to collect the sputum sample, send to the lab, they will culture it, they will extract the DNA. Then fourth part is preparation of DNA extraction. In the sequencing, they will check the previous data and they say that this drug is resistant. So DNA sequencing is the final report. So this is the report that we can get by the whole genome sequencing. So advantage of whole genome sequencing is a current alternative to a WHO approved probe method for tuberculosis for diagnosis and detection of a drug resistant genetic diversity. It also diagnoses the multiple bacteria which is combined with the tuberculosis. In a tuberculosis, you can find that bronchiectasis is also a cause and the comorbidity of previously treated patient. So that Mycobacterium TB is also there and another bacteria is also in the patient. So they will detect the another bacteria also in the WGS. The third thing is they can detect the single nucleotide variant and insertion, deletion, copy number of change and large structure variant. And finally, the most proper and advantage part of WGS, they can detect only 100 nanogram particle of DNA. So if your patient is a possibacillary nature, they will detect the sensitivity. So this is the WGS advantage. We can detect the WGS by 14 days if you go through the government guideline. We can detect whole genome sequencing by at the end of 18 days if you are again go with the government guideline. But if you are directly approaching the patient with WGS, you can get the report of within only 12 days. એ 12 ડેઝમાં જ આખે 18 ડ્રગ્સનો સેન્સિટિવ રિપોર્ટ આપણને આપે છે. So this will detect the 18 antibiotics. Specificity is 99.8, sensitivity is 85 to 98%. It is identify the mixed co-infection and another infection also. And the advantage is also it takes the NTM. So these are the list of drugs that the sensitivity report you can get in the WGS report. So now the most important part is case studies, that whether it is effective or not, a patient જોડે કોઈ ખર્ચો કરાવડાઈએ તો એ બેનિફિટ છે કે નથી. So this is one case. 27-year-old female complaining of cough with expectoration, fever and anorexia since 1 month. The diagnosis of sputum +2 in a AFB smear and sputum gene expertise, MTB detected with rifampicin sensitive. So this case is a proper sensitive tuberculosis case. We have sent the WGS also and we can found that each and every drug is sensitive. The green mark is suggestive of all drugs are sensitive. So treatment plan, we can get the report within 10 days and the treatment is drug sensitive tuberculosis. This is the second case. A 43-year-old male with cough, expectoration, fever and anorexia since 3 months. Sputum examination found to be +3, MTB detected and rifampicin sensitive in a gene expert report. So we also get the same report with WGS that Mycobacterium TB is found and each and every drug is sensitive. And the same time, the 12 days time, we can get the WGS report and this is drug sensitive tuberculosis. This is the third and most important part. The 63-year-old male patient, a known case of diabetes with dry cough, fever, weight loss since 2 months. Sputum examination was done, it is sputum AFB negative. Sputum gene expert is done and it is found to be Mycobacterium TB detected with rifampicin resistant. So this is the trap. Sputum first line LPA report is also to be rifampicin and isoniazid resistance. At the duration of time of the report of first line LPA is 30 days. First day WGS was sent and it was found to be isoniazid, rifampicin, streptomycin and ethambutol and the pyrazinamide. So all sensitive drug of first line tuberculosis are resistant in that case. So for this we have started the drug for shorter oral bedaquiline regimen And the advantage of this WGS is we can found the report within 28 days only. And the patient treatment start more early than the 2 દિવસ વહેલા સ્ટાર્ટ થઈ શકે LPA કરતા. The next case is 19-year-old male with CKD, known case of CKD patient. He is complaining of dry cough, fever, anorexia since 15 days. Sputum AFB negative, MTB not detected, but bronchoscopy was done for the unresponsive pneumonia and found to be MTB detected with rifampicin resistance. In WGS, same we can found that isoniazid, rifampicin, streptomycin and ethambutol is resistant with ofloxacin, moxifloxacin, getifloxacin is also resistance in that case. So for this we can found the report within 18 days and the patient is shifted to all oral longer. So 18 દિવસમાં પેશન્ટ ડાયગ્નોઝ થઈને ઓલ ઓવર લોંગર રેજીમેન સુધી પહોંચે અને હવે 18 થી 20 મંથ સુધી એ ટ્રીટમેન્ટ લેશે. ઇન જનરલ થતું હોય છે 6 to 9 મંથ પેશન્ટ ટ્રીટમેન્ટ લયા જ કરે અને પછી ખબર પડે જ્યારે કે હવે દેર ઇઝ નોન રિસ્પોન્સિવ ડ્રગ અને પછી આપણે એને ફર્ધર ઇન્વેસ્ટિગેશન મોકલીએ. ઇટ ઇઝ વેરી બેડ ફોર અસ એન્ડ બેડ ફોર ધ પેશન્ટ અને એનાથી ડિફોલ્ટર ધીરે ધીરે વધતા જાય છે. ધીસ ઇઝ અનધર કેસ 33-year-old male patient, same cough with expectoration, weight loss, sputum AFB +3, Mycobacterium TB is detected with rifampicin resistance. Here is the trap. With WGS, we have found that ofloxacin, moxifloxacin, getifloxacin, so all FQ regimen is resistant. Some of the general practitioner, even MD, even pulmonologists have tendency to add levofloxacin in the sensitive drug. But the patient is already found to be levofloxacin resistant, so there is no need to add levofloxacin. So burden of the different antibiotics are more with the lesser education level of the doctor. So the report is found to be in 10 days and drug sensitive TB treatment was given and patient is treated.
Sir, request to conclude the lecture in last 5 minutes. Thank you.
Okay. The 27-year-old female suffering from pulmonary TB with bronchiectasis. Since 5 months, she is taking treatment by the general practitioner with sputum-sensitive tuberculosis with levofloxacin. After end of 2 months, there is no radiological improvement was found. So history of TB is there in a childhood. The gene expertise suggests of Mycobacterium TB detected, but the culture is detected of Mycobacterium TB with all drug-sensitive TB. Fungal culture, no growth. WGS report attest that Mycobacterium tuberculosis detected with incomplete DST, rifampicin resistant detected. So this is the case of drug-resistant tuberculosis and sent to all other longer treatment. This is my last case. This is case of extrapulmonary tuberculosis. A 22-year male with recurrent right cervical and bilateral axillary with inguinal lymphadenopathy on treatment of TB drugs since 1 year on an empirical basis by a MD, and FNAC is not conclusive at that time. Lymph node excision was done and sent for WGS, and we have found that there is no mycobacterium growth, and cytology report is suggestive it is lymphoma. There is no tuberculosis in that patient. So WGS itself investigation that we can change the diagnosis also by the WGS. So this is the advantage of WBS. It costs 6,000. Culture DST costs 10 to 15,000. CBNAT conclusive of 2,000 and LPA is 4,000. So the આપણા પ્રધાનમંત્રીનો અત્યારે નવો ટાર્ગેટ ટીબી હારેગા દેશ જીતેગા. So this is my take home message. TGS is a single test to give a complete genomic sequencing for the Mycobacterium TB. It gives simple and precise result within a fraction of time, which is 12 days only, and patient-based treatment initiation starts early. So thank you so much. This is the Haystack company.
Thank you very much, sir.
Thank you
for giving so informative lectures on advanced treatment of the tuberculosis.